Hello, I'm going to be giving a talk on CT runoffs to exclude peripheral vascular disease, everyone's favorite topic at around midnight on call, particularly in those with background peripheral vascular disease. I'm going to briefly go over peripheral vascular disease, talk about some pertinent anatomy, and then get into the real bulk of the talk in terms of lesion characterization and approach to these studies, a little bit about reformats and post-processing, briefly go over some differential diagnoses, and then show some additional findings. Okay, very briefly, I'm going to talk about intermittent claudication. I'm sure we all remember from medical school, described as muscular pain, typically in the calf, given fempop disease is the most common disease that we tend to see in our patient population, while walking, that is relieved with 10 minutes of walking cessation. Obviously the thigh and or buttocks can be affected depending on the level of stenosis. The general rule being that the stenosis will cause downstream claudication. So calf pain, typically we'll find patients with stenosis in the fempop arteries, buttock pain with the aortoiliac arteries, and foot pain with the tibial arteries. Some pertinent anatomy. I like to describe the arteries of the lower extremity as the inflow and outflow vessels. Inflow being above the inguinal ligament, including the abdominal aorta and the iliacs. The common femoral is considered part of the outflow, being at and below the inguinal ligament, including the SFA, the profunda, which is an important collateral and surgical artery for bypass, as well as the popliteal and tibial veins, tibial arteries, rather. I'll start with the common femoral artery. The origin is anatomically at the inguinal ligament. From an imaging origin, the common femoral artery begins at the branches of the external iliac artery, that being the deep inferior epigastric artery medially and the deep circumflex iliac artery laterally. Believe it or not, there are three branches of the common femoral artery, typically. Sometimes there can be variants. We usually don't see them under CTA unless we really look hard, but they do play an importance, particularly in terms of trauma. Those three branches are the superficial inferior epigastric artery, the superficial circumflex iliac artery, and the external pudendal artery. The external pudendal, which can be a culprit of pseudoaneurysm following pelvic trauma. That's why we like to note the branches of the internal iliac as well as the common femoral in cases of pelvic trauma. The profunda is a very important artery, not only for collateralization but also for surgical bypass. There are two main branches, the medial and lateral circumflex femoral arteries. It's an important artery to comment on, even if it's just a brief comment on CT runoffs. I'll try to say something like they're patent, or it's patent, or there's a severe origin stenosis. That sort of information can be quite helpful. The SFA obviously begins at the common femoral arterial bifurcation, and it ends and becomes the popliteal artery as it exits the adductor hiatus, which can be tricky to see on CT. Typically, we know that it's exiting the adductor hiatus when it crosses in, posteriorly to the most medial margin of the femoral cortex, sort of right at this level. It's an estimation, but it's a nice landmark, this femoral cortex. So if there's disease affecting distally, I'll call it the popliteal artery, and proximally the SFA. And that's sort of my go-to in terms of an imaging demarcation. The popliteal artery will have 3 segments to it, demarcated by bony landmarks, proximal, mid, and distal. The 3 bony landmarks would be the medial cortex of the femoral metadiaphysis. To the top of the patella would be P1. From the top of the patella to the top of the tibial spine, that would be P2, and then from the tibial spine to the AT takeoff, which can be actually quite variable, as P3. So these typically hold true, and it's a nice way to describe the proximal, mid, or distal popliteal artery. The anatomy of the lower extremities, or the crural arteries. Sorry, the whole leg is the lower extremity. The anatomy of the infrageniculate arteries, or the crural arteries, can be quite variable, but typically the AT will pierce the interosseous membrane and traverse laterally. The interosseous membrane piercing is a common area of calcification and stenosis. Once the AT rises off the popliteal artery, the artery becomes the tibioperoneal trunk, which then bifurcates into the peroneal and posterior tibial arteries. The posterior tibial artery, of course, traveling behind the medial malleolus. In the feet, there are 3 main arteries, really, that we're concerned about: the dorsalis pedis, the plantars, medial and lateral, which end up communicating via the plantar arch, which it's important to indicate on the study and communicate whether or not that plantar arch is patent or not. Collateral pathways play a very important part, not only in terms of gauging chronicity of stenoses and underlying arterial disease, but also communicating their presence to suggest that there may be decent blood supply distally to these collateral pathways. Sometimes these collaterals can be very robust and actually provide enough blood pressure to perfuse underlying tissues. There are 3 main collateral pathways of the lower extremity. Those pathways being aortoiliac, fempop, and tibial collaterals. In this DSA image, we're seeing the superior gluteal giving a nice juicy collateral to a profunda collateral, which then supplies the SFA. And this is actually quite nice and robust, which suggests chronicity, but also perhaps adequate blood flow. Of course, we won't know that until we talk to the patient and learn their symptoms and possibly perform an ultrasound. On the right here, we're seeing a 3D reformat CT imaging showing a patient with aortoiliac occlusive disease and collaterals from iliolumbars connecting to the common femoral artery, as well as collaterals from the pathway of Winslow, or actually this looks like a circumflex iliac connecting to an intercostal, which is not the pathway of Winslow. But we are seeing the pathway of Winslow here from the internal mammary to the superior epigastric, connecting to the inferior epigastric, and then to the common femoral artery. Anyway, collateralization can be fascinating and important to mention. Oh, good, more collateral pathways. Here we're just, again, seeing some collateral pathways suggesting chronicity of an occlusion. We're seeing a nice, robust internal, deep inferior epigastric communicating to the superior epigastric, otherwise known as the pathway of Winslow. Another patient with, looks like aortoiliac occlusions and marked collaterals, suggestive of chronicity. So this is actually a nice example of how 3D reform, or in this case it's a 2D reformat, but I'm sure it is a 3D volume rendering reformat, aids in the actual diagnosis and visualization of collateralization. These are very nice to show patients actually the extent of their disease, and it's great when the technologists or whomever can work the software to create. Lastly, we're seeing here some tibial collaterals, which can arise from geniculates, or can arise from the tibials themselves, either the artery affected or other neighboring ipsilateral arteries. Also important to mention. Okay, lesion characterization. I've broken this off into three major categories: the morphology of the lesion, the degree of stenosis, and the length of stenosis. All three of these are quite important in communicating, not only for descriptive purposes, but for management and treatment and management purposes by the vascular specialist. Okay, moving into morphology. Essentially, the morphology of the lesion can be one of three: soft plaque, calcium, or a mix. That calcium can be further broken down into wall calcifications, concentric, eccentric, or big chunky coral reef calcifications. And it's important to mention what type of calcification, because this information can is very important from a management perspective in terms of how we're going to treat the patient with bypass surgically or endovascularly with angioplasty, stenting, atherectomy, or a combination. So these are three examples. On the left, we're seeing some nice soft plaque, a little bit of calcification proximally involving the popliteal artery. But predominantly this is a lesion with soft plaque. Oops. And in the middle, we're seeing calcified plaque, in particularly a very large coral reef calcification on this curved planar reef format. We have to be careful with these because we don't actually know if we're in the if we're mapping out the middle of the vessel, but at least on this image, it appears that there's a huge chunky, possibly occlusive calcification involving the common femoral artery. And then on the far right, we're seeing mixed plaque, which is typically what we see, mixed calcified and soft plaque, causing at least a moderate, if not moderate to severe stenosis. So speaking of moderate and moderate to severe stenosis, next we're going to be talking about the degree of stenoses, ranging from none to totally occluded. None being obviously 0%, mild 0 to 50%, moderate 50 to 75%, and severe over 75%, but less than 100%, because 100% is an occlusion. There are some varieties with this classification system. There is no gold standard in terms of describing the degree of stenosis. Some people will actually describe it anything over 50% as severe, but typically this is the sort of classification that most people use and most people are taught. So that's what I use. And in terms of where to measure the level of stenoses, this can cause some confusion. An example would be carotid artery stenosis at the carotid bulb. The Europeans like to go at the level of the lesion, whereas the North Americans, we like to find the normal adjacent vessel and make a ratio based on those measurements. Personally, I go by the lesion, where the lesion is itself in terms of determining my stenosis. So I'll find the diameter at the lesion and then the reference diameter at the lesion from wall to wall, and come up with a degree of stenosis or percentage of stenosis based on those levels. But do it whatever you're comfortable with and whatever you're used to. I just find it easier with our software to do it at the level of the lesion, because it's hard to get an automatic measurement in terms of ratios at two different levels with our PAC system. And I don't want to bust out a calculator or actually do math. I haven't done that in a while. Okay, lastly, the length of the lesion, which is also important in terms of classifying the lesion in question. The main reason being is because it affects how we manage the patient. There's a task classification system, part 2, that is actually now not so new, but still widely used in terms of assessing the degree of stenosis and potential management. So that's why we like to know the length. There are actually 2 tasks. Well, in terms of task 2, there are 2 classification systems, one for aortic and one for femoral pop lesion severity. And again, it does guide the management. And basically, in terms of inflow, length of stenoses, short or focal, I'll usually use the term focal, being less than 3 centimeters, intermediate 3 to 10, and long more than 10, whereas the outflow below the inguinal ligament, focal or short, is considered less than 5, intermediate between 5 and 10, and long greater than 10. The main reason being, I think at least, I haven't actually come across any reasoning behind these, but stents are actually, the iliac stents are approximately 3 centimeters in length, 2.7 actually, at least the ones commonly used, whereas the smallest length for fempop lesions are 5 centimeters. So I'm thinking that's why they came up with this classification system, but I'm not entirely sure. All right, the approach. How are you going to approach all these vessels and the incidentals? Well, basically, you have to cover what the vascular specialist wants to know. We've covered most of these. The location in terms of anatomy, morphology, soft, calcified, or a mix, degree of stenosis, mild, moderate, severe, and then the length, shorter, focal, intermediate, and long. We've talked about collaterals, perhaps overkill on collaterals. Next, we're going to talk about the runoff. What do I mean by runoff? Runoff essentially is describing the tibials and what tibials are opacified, in particularly inline runoff. So having a tibial patent doesn't have to be crystal clear, but it has to be patent. So from its origin until its termination at the mortise, essentially. So even if there's a stenosis, if you can still see contrast through and through without any interruptions, i.e. an occlusion, from its origin until the mortise, then that's inline runoff. And it's important to note how many vessels demonstrate inline runoff below the knee. Typically 3. Some patients have congenital absence of, for example, the posterior tibial artery. I think I've seen that twice, but you don't worry yourself about that. Typically 3 vessel inline runoff. And again, I go by the same degree of stenoses rules, mild, moderate, and severe. Just a little trick in terms of what's the anterior tibial. This is mostly on angiograms for exams, but when you see the AT and lateral, you know it's the anterior tibial artery. But that's for DSA studies. Okay. Like I said, checklists work. I find them to be extremely helpful in all of radiology, but in particular with these CT runoff studies. So I break my dictation into inflow, outflow, incidentals, and conclusion. Inflow being, I'll look at the aorta and its branches. I'll look on the right and the associated iliacs, then the left and its associated iliacs. Then I'll look at the outflow. I'll look at the entire right leg first, including the profunda, and then move on to the left. Incidentals, unfortunately, these patients are typically pretty sick at baseline. Their protoplasm is poor, and they've made some life decisions that perhaps they regret in terms of smoking and diet. So there are often underlying morbidities, and I don't think I've ever seen a CT runoff with at least one incidental. So it's one of those things that we need to look for. And then I have this little legend at the bottom of my reports going over abbreviations of the different vessels, what I mean by mild, moderate, and severe, and length, lesion lengths above and below the inguinal ligament. So in my reports, I don't actually do proper measurements. I don't mention, oh yeah, the right common femoral artery demonstrates a 72% stenosis. I'll just call it moderate. A moderate, shorter focal length stenosis. And then conclusion, I'll summarize the inflow and outflow vessels as well as describe the runoff, the number of runoff vessels bilaterally, and any pertinent incidentals. And by pertinent incidentals, I mean things basically like acute fractures or cancer are the ones that I commonly see, and I'll end up calling or emailing the physician because oftentimes they'll get lost in the body of the report. And honestly, a lot of times, especially on call, the surgeons may take a while to actually look at our reports, and they'll just look at the images to make a decision. So it's important really to hammer home or to communicate with the physician and any pertinent incidental findings. Just one thing I'd like to say, when there's a lot of disease in one vessel, I'll highlight the most pertinent and severe disease, and its length, and then I'll give a descriptive statement, and I'll say something along the lines of, there's a severe moderate length stenosis due to soft and calcified plaque involving the common femoral artery on a background of multiple areas of focal mild stenoses. But just to sort of paint an overall picture, you describe, where I describe the most important and severe lesion, and then paint the picture of, there are also other things happening with the leg, or with the artery. And here's my report. If you can find that magnifying glass that we all have in our drawers somewhere, feel free to copy and paste this from PowerScribe, but this is what my reports look like for CT runoffs 95% of the time, unless they're done immediately following a procedure. Again, I'll reinforce this. I just mentioned it, but if there are multiple lesions, I'll describe in detail the most severe lesion and then provide a brief statement of the background vessel. Essentially just as I described, and that sort of provides a nice sort of picture and can hint at a task classification lesion, which again guides management. I'm not going to go over the task 2 classification because none of you are writing your exams, and I don't want to take up too much time. All right, reformats and post-processing. These are typically done by the technologist, but not always. If they're missing, please feel free to call and ask them to do them on call. The majority should know how to do them. If not, the interventionalists, we typically do them when we're reading these studies on an outpatient basis. I find they really help, not only providing an overall picture, but the surgeons appreciate it too, because they can show the patients their images. So again, they can provide a very good overview, but each post-processing technique has its limitations, and the 3 that I'm going to be talking about, and the 3 that we use most commonly, are multiplanar reformats, MPR, volume rendering, VR, maximum intensity projection, MIPS, and curve planar reformats, CPRs. I'll just be going over these very, hopefully briefly. With this table, MPRs, what we're used to, taking an axial image and turning into coronal and sagittal reformats. Very good for determining diameter reduction. I like to use the axials at the level of the lesion, as I mentioned earlier. In terms of deducing the area reduction, it's possible. We tend not to describe the area anyway. That's more for academics, really. A whole overview of the vasculature is quite difficult with a single slice. Degree of lumen the degradation of lumen evaluation by beam hardening artifact from calcification or stent is pretty mild, and if present, it just takes some windowing and leveling. A drawback, the biggest drawback with multiplanar reformats is that it's difficult to get an overall overview and lesion length, just because of the inherent nature of the single 2D slice image. Okay, volume rendering. This is essentially a 3D overview with where the software assigns Hounsfield units to be visible or invisible. Sometimes the contrast and calcifications and bones can be intermixed, and it can be tricky to sort of determine what's real and what's not, but generally these are quite good. It's possible to obtain a diameter reduction, but again, because of if calcifications are present, that can definitely, or a stent, it can cause a significant overestimation of stenoses. Area reduction, we don't really care about, really, to be honest. Vascular overview, this provides an excellent 3D overview of the entire vasculature. We can get degradation of the lumen by calcifications or stents, but again, a drawback is that it relies on a threshold unit, and therefore, these high density objects, such as calcifications or stents, can limit the visibility. MIPS can be very, very useful. I tend not to use them unless I'm giving talks, because I find the volume rendering provides just as much information as the MIPS. The MIPS are a 2D image, obviously taken where software takes the highest attenuation voxel in a specific volume that we input and provides basically a DSA overview. It's pretty good with determining diameter reduction. Area, I'm not going to talk about. Provides a nice vascular overview, just like a DSA does. Unfortunately, with the MIPS, you get the worst degradation of lumen, so I don't usually use them. I'll show you an example shortly. And again, stents and calcifications is a big drawback, so anything with a high attenuation can obscure intravascular contrast due to this beam hardening. And one way to overcome this issue is to really use a high window to help with the contrast. And curved planar reformats I love. I do these on all of my studies. Texts don't typically do them, but I'll do them because it really provides a very nice overview. Basically, where we select the curved plane that we want to use as an imaging center point along the opacified lumen of the vessel that we're interested in. I think it's pretty good for showing diameter reduction. If you select your center point and your tracking point adequately, it gives you a nice vascular overview. There's very little degradation of the lumen by high attenuating objects, particularly if you make your own tracing within the lumen. But again, that's the main drawback, is that the images depend on the course selected. The software does an okay job, but I find I often have to tweak it, and unless you know how to tweak it, it can be very challenging and almost useless if the software itself selects a poor selection of the plane. So multiplanar reformats, we know what these are all about. As an example, let's take a look at this common femoral artery here. We're seeing that there's a severe coral reef calcification, and on this view, I argue that this looks entirely occluded, but when we go on our 2D image, we see that there's a little bit of contrast going through, so it's a near total occlusion. But again, we're not getting an overview of the vessel, of the vasculature. We can get an idea that this patient has poor vasculature, but we just don't know until we scroll through all the images. Volume rendering, two on the left are the same patient with calcifications and then with calcifications removed. When the calcifications are removed, you can see that this patient probably has chronic total occlusions. from the common femoral artery bifurcation all the way to the tibials, and that's supported by these collaterals. And then on the right, we're seeing aortic occlusive disease. These are great for the patient and for the surgeon and for us too, because it provides a really nice overview of the overall disease, especially the collaterals. Wow, I love those collaterals. MIPS, again, this is the 2D reformat imaging. It's DSA-like, where you're taking the highest attenuation voxel in your specified voxel volume and rendering it as an image. It provides a nice vascular overview, but we can't really determine the amount of stenosis or degree of stenosis. For example, this common iliac, I don't know if this is moderate or severe or mild. Tend not to use these MIPS unless I'm giving talks like this. I love the curved planar reformats, especially if I'm selecting the reference point. This provides a nice vascular overview, and you can really see where the stenoses are located. For example, in the adductor canal here of the right SFA, there's a severe stenosis due to this large chunky coral reef calcification. It provides a great overview. And there it is, in case you don't believe me. There is a tiny bit of contrast. Again, the software would probably not do this very well in terms of selecting the lumen, so I would have to go in manually and select the actual lumen that's being opacified, but that's beyond this talk. Oh, and just an example of how high attenuation objects can limit assessing the degree of stenoses. We have a MIP versus a curved planar reformat. Bilateral renal artery stents. I can't tell if these are patent or not based on the MIP. However, on the multiplanar reformats, I can see that these stents are overall pretty patent, although we do have a little bit of inflow disease there on the right. So putting it all together, I do utilize these three, obviously the source images and the MPR reformats, or the MP reformats. Utilize the volume rendering images with and without calcifications, and then the curved planar reformats. All right, we're almost done. So not all runoff studies will reveal simply peripheral vascular disease. There are other pathologies, which I'll be getting into, and particularly emboli. But first, a note on aneurysms. Aneurysms can occur anywhere, but most commonly the aorta, which is defined, an aneurysm defined greater than 3 centimeters, can be there. There are various classifications, but this is the one, and these are the classifications that I use for the listed vessels. Common iliac, over 2.5 centimeters, external iliac over 1.2, and popliteal over 1.6. These are, in my opinion, kind of silly numbers, so I actually go by the nearest whole number. Well, the nearest simple number being 1 for external iliac and 1.5 for popliteal, even though really the popliteal artery aneurysm is defined as 50% more than the background normal artery, but we don't need to get into that. If you note a popliteal arterial aneurysm, there's 50%, half of those patients basically will have a contralateral popliteal artery aneurysm, and also half of those patients could have an abdominal aortic aneurysm. Other common sites, common iliac and internal iliac arteries. For some reason, we just don't often see the external iliac arteries demonstrating aneurysms. Don't know why. That's a good idea for the researchers. Emboli. So these can be tricky. Oftentimes we'll get requisitions suggesting or wanting to rule out acute on chronic peripheral vascular disease, and these can cause palpitations in all of us, really, because it can be hard to elucidate what's acute and what's chronic, or what's acute on chronic. Especially, like, in particular, determining what's an acute embolus versus a chronic soft plaque. Obviously, this can affect management. Acute emboli should be treated immediately. That reason being that collaterals have not developed compared to those with chronic disease, where collaterals have had time to develop due to all these angiogenic factors. Some hints and tips in terms of determining acuity versus chronicity. Again, look for collaterals that suggest chronicity, although patients can have acute on chronic disease, so that's not always helpful, but it is helpful particularly in younger patients. Look for signs of acute embolism. This is what I rely on. So look for a source, such as an LV thrombus or an aneurysm, popliteal or abdominal. Look for the so-called meniscus sign, or a linear, irregular looking thrombus that seems just to be flapping in the breeze. And I'll show you some examples. Look for, again, other signs of emboli. Look at the renal arteries. Emboli like to go there. They like to go to the spleen, the liver, SMA. Look at the renal parenchyma and the splenic parenchyma to see if there are any peripheral wedge filling defects to suggest ischemia from an embolic phenomenon. And again, chronicity, collaterals, and plaque can be helpful. So this is a very nice case. This is a patient who has background atherosclerosis, but has an acute cold and painful left leg. And if we look at the LV, we're seeing this sort of mildly fatty focus that could represent a source of a potential embolus. It's tricky to tell without an echo, and this is image 1, but it's just a little bit more hypodense than the underlying papilla. So this could very well be a thrombus. And then we're seeing this sort of a waning crescent moon with this, oops, oh yeah, there it is, yeah. This waning crescent moon with this peripheral plaque or peripheral thrombus. This just doesn't look normal on axial imaging, and it has this kind of weird meniscal shape to it. This isn't quite the meniscus sign, but this just isn't a normal shape. And then when we move to the coronal reformat, we're seeing this irregular plaque that's just sort of floating in the breeze here. Again, very abnormal. Chronic plaque does not look like this, unless there's been a recent intervention and we've dissected some of that plaque. But this reminds me of a windsock with this little bit just ready to fly down and find a new home. Another example of a meniscus sign. Here we have a femoral artery with an acute embolus, and there's the meniscus sign there. It's a nice convex meniscus. And this is the same patient with their right leg, and we're seeing the tibioperoneal trunk here with, again, a concave meniscus. Chronic plaque does not look like this. So we can be fairly confident that this is an embolic phenomenon. Well, this is an interesting case from a couple weeks ago. In this patient with a AAA and this windsock type of plaque within the aorta, just waiting to fire off, probably down the right leg, because we've got our nice little Lion King cliff here to avoid the left common iliac artery. And lo and behold, this patient had an embolus to their right profunda. Here we're having a nice little convex, or did I say concave before? I meant convex. A nice convex meniscus sign, and then unfortunately also to their superficial femoral artery, a nice beautiful convex meniscus sign. So unfortunately he threw an occlusive embolus to his profunda and to his SFA. All right, briefly go over 3 other arterial pathologies. Arteritis, which we don't see very often, but in terms of thromboangiitis and obliterans in patients with smokers, you can get occlusive disease of the tibials with these corkscrew collaterals supplying either the same vessel or another vessel downstream. Congenital or acquired abnormalities, these are fun. Post-cardiac cath, patient number 1. Sorry, cardiologists. This is a patient presenting with a swollen leg. And we're seeing one of these sides is not like the other. We're seeing a vein light up on the right and not on the left. This common femoral vein should not be lighting up like this. This external iliac vein should not be lighting up like this. It should look like the one on the left, and lo and behold, this is an AV fistula post-intervention. These are beautiful 3D rendering and 2D MIP images showing this early femoral venous filling and filling of the IVC. So this patient would need intervention. Cardiac, sorry, cardiologist. Let's just say post-intervention patient. Whoops. Patient with a growing right inguinal mass following a procedure. A nice little pseudoaneurysm here. Again, these patients. This patient from before actually was presenting with some claudication because of a steal phenomenon from this high flow AVM. I forgot about that. So we do see these on call. In patients with suspected claudication from PVD. Very rarely will we see other etiologies such as a high flow AVF post intervention. And back to the pseudoaneurysm, this is a growing mass post intervention, obviously pseudoaneurysm which we injected thrombin into. External compression, these are fun. These are typically in healthy patients. I remember this was I think a 32-year-old guy with a painful left foot. And if you can see very subtly, there's flattening of this popliteal artery. And this is the so-called popliteal entrapment syndrome, typically from a hypertrophied medial gastrocnemius tendon. Very interesting case, very subtle. This is one of those cases, actually, where every single slice of the image matters. It's unfortunate because there are 1,800 images sometimes with these CT runoffs. And in this case, I believe only 2 images on the axial demonstrated this narrowing. I can't even really see it on this curve reformat. It's somewhere around here. It's not very convincing, but I think with dynamic imaging, it would be even more convincing if we had access to a dynamic ultrasound. So not everything is peripheral vascular disease. Oh, and then U of T's favorite, cystic adventitial disease, which I've seen once in Scarborough, and the images weren't very good, so I didn't include the images in this talk, so I stole this from the internet. But cystic adventitial disease, for typically in the popliteal artery, where the adventitia can develop these cysts, which can have mass effect and cause stenosis of the artery and otherwise normal arteries. Additional findings. So very briefly, these patients tend to not be the healthiest of bunches of patients, and unfortunately this is a case of someone who had a CT runoff at, in July of I think 2016, and then in 2017 came to see us for an intervention, reviewing the CT scan, and we saw this. And we looked back and we saw this, which neither was mentioned in the report, but it was identified during the day of intervention. Needless to say, the patient didn't have the intervention, had surgery first, and then had the intervention a few months later. But these patients tend to be sick, and tend to be not actively sick, but just older and prone to disease, so it's important to look at everything. Another patient with a nice tumor on their kidney, just showing that every little image counts. Excuse me. This patient had leg weakness, essentially normal vessels, but these compression fractures, and we can kind of see a disc bulge at L3/4, possibly causing their symptoms. Let's see. Oh, this was a patient with a left groin lump. They had a CTA runoff to exclude. I don't know what to exclude, but they had abnormal lymph nodes. A history of thrombocytopenia, never before diagnosed splenomegaly. So that was a new finding of splenomegaly, so that was interesting. And I think this is, lastly, left groin pain, exclude aortoiliac occlusion. They had a normal aortoiliac system, normal femorals, but they had a large hydrocele, possibly not really their groin, but that was the only finding. And that is that. Thank you for your time. Sorry for the recorded video, but if you have any questions, please feel free to contact me and ask me. Okay, thank you.